Well, this is part 5 of chapter 21 on respiratory dysfunction, and we're going to look at cystic fibrosis now. Cystic fibrosis, the GI tract and the respiratory tract are the two most affected parts of the body. However, it does affect everything. It causes increased viscosity of secretion. So all exocrine glands, everything that's excreted, is extremely thick. And it does that, it's the chloride channels in the cell membranes are affected, so it interferes with sodium and chloride movement, making these thick secretions, which then they can't get out. They'll dilate whatever ducts they're in, precipitate and turn hard, form concretions, and then in the long term destroy those glands and ducts. And that's what happens inside the pancreas over time. So the basic defect, you have this exocrine gland dysfunction where everything is thick. So it happens in the lungs, down in the bronchi where the secretions are so thick they can't cough them up. Old mucus sitting becomes a great medium for germs to grow. So they have kind of chronic pneumonia. In the small intestine, in utero, sometimes these babies will be born with meconium ileus, that they won't pass the meconium because everything is thick. That's not always true, but can be a sign of cystic fibrosis. The pancreas, the problem is it destroys those ducts over time, so you're not getting the pancreatic enzymes which are supposed to break down your fats in your gut. They're not able to get out of the pancreas, so you don't digest fats. You don't break them down, you can't absorb them, you can't use them, so you end up with a malabsorption system, and then over time it destroys the pancreas itself, so these kids are at a high risk for developing type 1 diabetes later on. And the same thing happens with the bile ducts, and again you get those concretions inside there which does damage to the liver itself or the biliary ducts, and you can get portal hypertension. So those are kind of longer term issues. So what we see, this pancreatic enzyme deficiency, they have large fatty stools because they don't absorb it. They have respiratory issues, kind of chronic progressive COPD basically. Sweat gland dysfunction. Parents will say they taste salty when they kiss them. Failure to thrive from that malabsorption. So they can eat like crazy and still lose weight. And then gradually their respiratory will deteriorate as well. So how do they look when they come in? Well, respiratory issues, wheezing, dry non-productive cough. And it's not always dry is an interesting word because it sounds like there's stuff there, but it's so deep down in the lungs they can't necessarily bring it up. So it's kind of an obstructive emphysema. Yeah, on an x-ray, they'll say they see patchy atelectasis, so there's little collapsed areas all over. They look cyanotic because they don't have good gas exchange going on. You'll see clubbing of the fingers and toes. That takes about 6 months of chronic hypoxia to develop. So that's a sign when you see that this has been going on a while. And then they get bronchitis and pneumonia. They usually come in with respiratory problems. So I said meconium ileus occasionally happens with these kids, and that's your earliest sign. They're also at high risk for prolapse of the rectum because they have these huge, bulky, fatty stools, or just intestinal obstructions. They get those fatty, foul-smelling stools, and because they're not absorbing, they get wasting of tissue. Here's a picture of clubbing of the fingers. You can see the tips are wider and the nails are kind of curved funny. And that happens on the toes as well. So other things that it causes, if you're chronically hypoxic, you're going to go through puberty later. You're not going to grow as well. Males will be sterile. As I said, parents say their children taste salty. They get dehydrated because they have electrolyte issues, and they have electrolyte issues, and also albumin, low albumin, because they just don't absorb through the GI tract. So how do we diagnose this? The best test we use is a sweat chloride test, and it's exactly what it sounds like. They put a little disc on the skin, collect sweat, and look at how much chloride is in it. And that's the definitive diagnosis. Chest x-rays show that chronic pulmonary problems. Pulmonary function tests will tell us how much chronic pulmonary problems we have. Those stools, we're going to look at their stools to see how much pancreatic enzyme they need. Since they can't make it or can't get it out of their pancreas, we give it to them every time they eat. And it really is, we give them as much as they need to have fairly normal stools. Then they can do a barium enema if there's a problem with them, if they're looking for obstruction or something. So respiratory, how severe it is varies from patient to patient, but they all have some respiratory complications. And it comes from this thick secretions that sits in the bronchi, causes plugging, which causes little areas of atelectasis or hyperinflation, either traps the air in or prevents it from getting in, but that old mucus sits in there, gets hard, and becomes a great medium for bacteria to grow. So this is gradual and progressive with these chronic respiratory infections. And it does some permanent damage. The epithelium is destroyed, and then that spreads. It is replaced with fibrotic tissue, right, scar tissue, which doesn't work, doesn't stretch, doesn't do gas exchange, and so you end up with this chronic hypoxia. So they are like your COPDers, right? They run a chronically high CO2 and a low O2, and you have to be careful how much oxygen you give them, because their oxygen is now what drives their respiratory. And I think I kind of just said some of this, but that chronic hypoxia also does damage that then changes the vessels, the vasculature of the lungs, and so you can get pulmonary hypertension and other related complications. So the GI tract, the problem here again, it's those thick secretions. It plugs up the ducts that should be putting pancreatic enzymes into the intestines, and so they don't break down food. They also don't absorb well. Partly it's not broken down, and partly they just have this thick mucus that they've got to absorb through, so they get these abnormal stools. These kids, we let them eat as much as they want, and they still have trouble gaining weight. We often have them on a continuous feeding at night just to try and maximize the calories going in, because we know they'll absorb such a small percentage of the calories that go into their gut. So every time they eat, we're going to give them those pancreatic enzymes. And the other function of that pancreas is your beta cells making insulin, right? So that becomes a issue as well. They're high risk for diabetes mellitus type 1 because the pancreas gets damaged and then it doesn't work. So our treatment goals to try and minimize pulmonary complications, get them to grow as much as we can, and that's part of why we do that nighttime feeding, and then just helping them and their family adjust, because this is a chronic illness. Most of these kids are on all of the treatments you're going to see at the hospital. They're on it at home. The only thing we add is IV antibiotics. So they get CPT, they take bronchodilator medications, they do forced expiration, that huff breathing. We teach them, breathing exercises. So then when they get hospitalized, we add IV antibiotics and perhaps aerosolized antibiotics. So here he's doing This is a breathing exercise, trying to clear the mucus. I've only seen this used occasionally at children's. They much more often do CPT and just coughing and deep breathing. And concerns, pneumothorax, hemoptysis, nasal polyps, all this stuff happens. We have them on steroids or non-steroidal anti-inflammatory drugs. They may over time need transplant. These kids sometimes need lung transplants, sometimes need intestinal transplants. Just kind of depends on what is more serious, and hopefully we're able to get that before enough damage has been done that they're not a candidate. And here's a little girl with her CPT vest. So this is pneumatic. This machine over here is going in one tube and out the other and doing little pounding. They say it feels like a massage, kind of that rough part of a massage. And they're funny, they'll be talking and playing, and you hear their voice bouncing along with the CPT machine. So GI, giving them pancreatic enzymes every time they eat. For an infant, we'll open those and dump them in a spoonful of whatever, applesauce or purees. Older kids, they're a capsule that they swallow. The enzymes themselves are little balls that are enteric coated, so you can't smash them, but you can open the capsule and dump those little balls out. We give them high protein, high calorie diet, really as much as they will eat. We worry about that rectal prolapse and obstruction, so treat constipation, and then if you get a prolapse, that has to be reduced. Salt supplementation. There is no limit to how much salt these kids can eat. And then if they're refluxing, keep them upright after meals. We give them handfuls of meds every day. It would give anybody reflux. Endocrine management. They're at high risk for diabetes, right? So monitoring blood glucose levels. We need them on that high calorie, high protein diet, but encouraging exercise and checking the eyes, right? The high glucose can do damage to the retinas. So the prognosis, it's getting better all the time. In 2008, it was 37 years, a little over 37. The ones you're going to see the most at the hospital are the more serious, and they are not going to live to be that old. So it's a genetic disorder, and so then we've also got to deal with the parents' guilt, because the parents, we have to have 2 carrier parents to pass it on to their children. So organ transplant sometimes helps, and maximizing nutrition. So as I said, family support. This is genetic, so making sure the parents are not feeling guilty. Expect on the exam a question about how this is passed on. This is your standard old recessive gene, which means both parents are carriers. Each parent has a normal gene and the abnormal gene. Each parent gives half of their genes to one kid and half, or every child they give either one or the other. So when you have 2 parents who are carriers, 1 out of 4 children is going to have the disorder, 2 out of 4 will be carriers, and 1 out of 4 is the lucky child who got the normal gene from both parents. So expect a question about that. Respiratory failure. We are treating this kind of all the time because they usually die from respiratory complications. And so we're doing what we can to maximize ventilation and gas exchange and increase oxygen, decrease CO2 as much as possible, and doing what we can, especially as they get more serious, in decreasing oxygen demand. CPR, just no kids. You're going to do respiratory first because usually they get a respiratory arrest before a cardiac arrest. And if you